This is The Rounds Table. Welcome back, Rounds Table listeners. This is a solo episode. I will be covering another practice-changing trial that was presented at ESC, European Society of Cardiology, in August of 2025. This was simultaneously published in a little-known journal referred to as the New England Journal of Medicine. The study, Aspirin in patients with chronic coronary syndrome receiving oral anticoagulation, the aquatic trial. I don't know why they're calling this chronic coronary syndrome. Apparently, it's the new name for coronary disease. I really don't like it, so I will stick old school. And the backdrop here is that after somebody has had an MI and then a stent, if they have an indication for both anticoagulation, say they have AFib, as well as antiplatelets, aka their stent, what's the safety and efficacy of both of these together? There have been a couple prior trials in this space, which maybe I will get to towards the end of this podcast episode, but that hopefully sets the stage, right? It's that patient who you're seeing and they've had multiple stents placed, and maybe they also have AFib, and I don't know, 6 months after the stents were placed, you're sort of asking yourself, geez, do they need to still be on aspirin as well as their DOAC, or can I stop the aspirin? So with that in mind, let's get into the details of the study design. This was a double-blind, placebo-controlled trial run in France from 2020 to 2025. They included patients with CAD with a stent insertion more than 6 months prior, and they had to be at high risk of a thrombotic or vascular related complication and currently receiving long-term oral anticoagulant. So a bit more detail here. The inclusion, adults age 18 and up, all had an indication for anticoagulation, most often atrial fibrillation. And they had to have a high-risk feature for a coronary or vascular event. This could have included a past history of chronic kidney disease, a past history of diabetes, if they had multi-vessel disease, and they had to have at least one stent that was placed in that event 6 months prior. And we know that patients who have multiple stents placed, especially if it's like one stent after the other in, say, like their LAD, that puts them at an increased risk of thrombotic complications. Key exclusion criteria: patients are at a high risk of bleeding if they had an upcoming PCI, if they had a recent stroke, if they had severe chronic kidney disease, or severe hepatic failure. The intervention, aspirin, 100 milligrams once a day, and the comparator was placebo. So what that meant is that in the intervention group, they were getting both aspirin and their anticoagulant, and the comparator group, they're getting their anticoagulant and a placebo that looked like aspirin, tasted like aspirin. The primary efficacy outcome here, a little bit of a mouthful, but it included death from cardiovascular causes, myocardial infarction, stroke, systemic embolism, coronary revascularization, or acute limb ischemia. Their key safety outcome was major bleeding. So they randomized 872 patients. For the baseline characteristics, average age of 72, 85% were male, 40% had diabetes, a third had CKD, and a third had heart failure. What did they find? Well, the trial was actually stopped early after a median of 2 years of follow-up because of an excess risk of death from all causes in the aspirin group. That's, of course, not a good thing and is a very important reason to stop a trial. If you are finding a higher risk of all-cause mortality with your intervention, that is a reason to stop ASAP. So for that primary efficacy outcome, again, that was the composite of such things as MI, stroke, death from cardiovascular causes, as well as a couple other complications. That occurred in 17% with aspirin and 12% in the placebo group. So that's a 5% increased absolute risk with aspirin, and the hazard ratio showed a 50% higher event rate with the aspirin group on the relative scale. In terms of all-cause death, That occurred in 13.5% in the aspirin group and 8.4% in the placebo group. That corresponded to a 5% increased absolute risk of all-cause death, and on the relative scale, a 70% higher relative risk of the event of all-cause mortality. And then finally, major bleeding occurred in 10% in the aspirin group and 3% in the placebo group. So a 7% increased absolute risk with aspirin, and on the relative scale, a threefold higher relative risk of major bleeding with aspirin. A few limitations. First off, kudos to the authors for pulling this off. This is really, really impressive. It's hard to criticize a large, well-conducted, double-blind, placebo-controlled randomized trial. We know that whenever a trial is stopped early, sometimes that can lead to spurious results. But I'm not criticizing the authors for stopping early. They had to do this ethically. But that's something that always floats through my mind, right? When you stop a trial early, how robust are the results? It's ideal if there's other related studies or future studies to reproduce some of the findings. And fortunately, there are actually already multiple other trials in this space. So, a few of them. There was the AFIRE trial, that's AFIRE. There's the EPIC-CAD trial and the OAC alone trial. So there's actually been 3 previous trials in this space. In the AFIRE trial, it demonstrated that in older adults with coronary artery disease, that rivaroxaban monotherapy was non-inferior for prevention of cardiovascular events and at a significantly lower risk of major bleeding. Similarly, for the EPIC-CAD trial, which we covered on the podcast, a long time ago now, but similarly, it showed a higher risk of bleeding if you were on both an anticoagulant and an antiplatelet. That trial had a very low event rate, so it didn't give a strong conclusion for whether or not it would affect the person's risk of cardiovascular events. But when we consider, those 2 trials, as well as the OAC alone trial, which I haven't discussed, and this current trial, the aquatic trial, it really feels as though for patients who have a stent and it's been there for at least 6 months and they have another indication for full dose anticoagulation like AFib, we should probably be stopping the antiplatelet and they should be on just the oral anticoagulant alone. Very curious to hear from our cardiology listeners if they disagree and how they're currently sort of navigating this clinical scenario. But I think that the aquatic results provide us the most robust and best available data. And in this case, it shows that the continuation of an antiplatelet and an anticoagulant leads to a markedly increased risk of bleeding. And it also potentially leads to an increased risk of all-cause death. So that's it for this episode. 8 some odd minutes. I think that's all I have to say about the aquatic trial. It would be great to hear feedback from listeners. Good stuff. What good stuff do I have on my end? I don't know if I have anything original, to be honest. Trial Files is still going strong. Trial Files delivers and summarizes 3 practice-changing trials to your inbox twice a month, so sign up if you aren't already. We also have a cardiology Trial Files and IBD Trial Files, to name just a few. Going forward with Trial Files, we'll actually start summarizing guidelines, so sort of giving the reader top 5, top 3, some odd take-home points. If people think that's a terrible idea, do let me know, but otherwise we hope that it will be useful and just another piece to help you stay up to date by leveraging AI. All right, that's it, listeners. Stay well, and thanks for tuning in.
The Rounds Table is hosted online at medicinepods.com, your one-stop source for comprehensive internal medicine education and evidence-based medicine resources. We can also be found on all of your favorite streaming services. You can also follow us on Instagram, LinkedIn, and X. And special thanks to our audio editor, Tamara Van Bakel.